to another episode of Ask the Experts this morning, a platform that has been made possible by the Namibia Media Trust and, of course, the DW Academy. And it's a platform where journalists get to ask the experts on anything COVID related. Welcome. I see we've got quite a few participants already that have joined. Dr. Dziuban has also joined. So I think we can get started. I'm Nina Katangana, and I'll be navigating today's discussion. Now, today, we only have one guest, and that we'll be speaking to. That is Dr. Dziuban, who is the CDC country director, and of course should be no stranger to us as media practitioners. So, Dr. Dziuban, good morning and welcome. Thank you so much for joining us here on the platform. Now, today's discussion will be around HIV and COVID-19, two pandemics, one solution. Dr. Dziuban has also said to leave Namibia, so of course we want to take this last opportunity to pick his brain. Dr. Dziuban, good morning.
Hey, good morning. How are you?
Fantastic. How are you doing?
Well, thank you. Thank you.
Now, Dr. Dziuban, I'm sure you won't remember because, since the pandemic hit, a lot of discussions on lots of different platforms with a lot of different practitioners. But right recently, I think we were into lockdown about 2 weeks. That was still in March last year. And I had the opportunity to in another setting. And one of the things I actually did ask you that day was around, HIV and COVID-19. As a lot of information was coming through, and we knew that individuals who had underlying health conditions or comorbidities, if they contracted COVID-19, were at higher risk from the virus. For the life of me, I don't remember what your response was. It was a year ago, and I've had many questions around COVID-19 and its add-on since. Perhaps you can just start off by giving a of what the stats and realities, around were before this pandemic.
Sure thing. And I'm sorry, you've been cutting out a little bit, and I don't know if I am as well. I hope you can hear me okay. Okay, good. Yeah, and I think you're asking about the relationship with HIV, TB, other viruses, other illnesses that we already had here in Namibia, and now how that's playing out with COVID. We are still learning about it. I know people hate hearing that a year later, but as the COVID pandemic evolves, we keep getting new information. We definitely can say that if you have really any condition which weakens your body in any way, it means you're probably more likely to have a bad outcome for COVID. And that just makes sense. I think we can all understand the concept that if your body is weakened by kidney disease or liver disease or cancer or high blood pressure, or anything else where it's putting extra stress on your body's systems, that something like COVID that comes in and brings new stress, brings a new attack on your body's gonna have a harder time fighting it off. With HIV specifically, we have seen evidence that people living with HIV are more likely to have a bad outcome. But that's certainly more true if their HIV is not under control. And that's the nature of HIV. Not controlling that virus, the human immunodeficiency virus, HIV. When you're not controlling it, the main thing it does to hurt you is to make your body weakened against all the other things out there, including some germs that most people's bodies would just instantly reject, that wouldn't even cause the slightest symptoms in most people. If you have uncontrolled HIV, those germs, those viruses or bacteria, they can just swell up in you and even kill you. That's the nature of what makes HIV so horrible. So we know that if your HIV is uncontrolled, that you would have more risk of COVID or anything else. In some ways, I'm a little more worried about TB, tuberculosis, because that's also very common here in Namibia. Namibia is one of the countries with one of the highest rates of TB around the world. It's very much linked with the HIV epidemic. We know that a lot of the people living with TB in Namibia also have HIV. TB mostly affects people's lungs, and we know that that's often where COVID is doing the most damage as well. So there, we're not just talking about your overall body being weaker against the COVID virus. We're talking specifically about the lungs. So having a weak spot exactly where COVID likes to strike the hardest. So we do have to be careful for these vulnerable populations. But more than that, what we've seen throughout this pandemic is that things like being older, right? So being above 80 years old is going to put you at a lot of risk of a bad COVID outcome. But then being over 70 is still more risk than being younger, right? Every age you go down, it gets a little better, but you can see that there is still that increased risk for people who are older adults. Fortunately, we're seeing usually good outcomes in children, but not 100%. And I hear too many people saying, well, I have these young, healthy children. I'm not worried about them getting this virus. They'll just fight it off. Well, they might, but we see hospitalized children. We even see children dying from this virus. It's not worth the risk. Our children's lives are too important. So we still need to work to protect them as well.
Dr. Dziuban, I know that when this pandemic, first started last year, it took everybody for a loop. It was unexpected. I want to know how much of a backseat did HIV treatment have to take in order to make room for COVID-19, and the demands that came with navigating this pandemic?
So fortunately not. I'm actually really proud to report that. The HIV team in Namibia is amazing. CDC, my team, we work very closely with the Ministry of Health on HIV. We have for many years, for over 16 years, long before I got here. The Ministry of Health was fighting HIV, and CDC has been a part of that. There are other partners as well. USAID, also from the US government, partners like UNAIDS and WHO, which we call multilateral partners. They're part of the United Nations family. And then other organizations, some of them that get funding through the US government, through PEPFAR, other ones as well. It's a big team of people focusing on HIV. And what I'm really happy to say is it did not take a back seat. That team really focused on making sure that we didn't lose ground, because we've come so far in, especially I would say the last 10 years in Namibia, on progress on HIV epidemic control. And the last thing we wanted was to see that progress get knocked back 2 or 5 or 10 years because of COVID. Instead, actually, a lot of innovations went in. So specifically, I can name a few that actually got accelerated during COVID. So the first thing we did was say, everyone has to be safe. We can't continue things that are not safe. We can't put our health workers, our health volunteers, our clients living with HIV, we can't put them at extra risk. So some things did have to stop for a little while. Things like counseling, in-person counseling, in-person support groups, procedures that were not urgent. Those things had to be paused in areas that still had a lot of COVID transmission. And we actually started making a map every week that we were using within PEPFAR to say where things like trainings and support groups could continue and where they needed to be paused based on the risk from the spread of COVID. But there were other things that could be accelerated. So getting your medicine, not just 1 month at a time or 2 months at a time, but 3, 4, 5, even sometimes 6 months at a time. If you are living with HIV and stable, your virus is suppressed, we actually rolled out ways for people to get more medication for longer periods of time so they didn't have to go to clinic as much. And that kept them from being exposed to COVID in the clinics. And it kept the clinics from being as busy doing HIV medication refills when we knew they were already very busy with people with COVID symptoms. So that's one example. Another example was the borders. We know that the borders closed down for a long time, but the reality is there's a lot of people, especially in southern Angola, who completely rely on the system in Namibia to provide their HIV medicine. And it's not an overwhelming number of people. It's not bankrupting Namibia in any way. And if we were ignoring those people and saying, go get your medicine from your own country, that would hurt Namibia as well, because we know there's a lot of people going back and forth on those borders, and uncontrolled HIV in southern Angola would mean more new infections in northern Namibia. Instead, the Namibian approach has been to provide those services for the Angolans, but we couldn't just say, come across and get your medicine in a clinic in Namibia anymore, because the borders were closed and we didn't want to have that COVID risk. Instead, Namibia reached out and found ways to actually bring those medicines up to the border, sometimes even getting in a boat and bringing it across the river and handing it over. Really innovative ways. It's actually something that I've heard colleagues in a lot of different parts of the world talk about. They've reached out to Namibia to ask questions. How did you do that? Because it really was seen as a best practice. So no, fortunately I can say HIV did not take a back seat. If anything, the team found new ways to get the care to people who needed it in even better ways because of the pressures that COVID put on. People were stretched, to be sure, because you had people, not just myself, but a whole lot of people who were focusing on HIV that also had to think a lot about COVID now. But using innovations, I think we were able to see success on both sides.
That's actually so fantastic to hear, Dr. Dziuban. And just a note to the journalists who are joining us via Zoom this morning, if you do have any questions, please do put it through in the comment bar, and then you can filter them through Dr. Dziuban. But based off of what you said, Dr. Dziuban, really saying that, there was a handle on things concerning the treatment around HIV, and making sure that individuals who are in need of medication received it on time, and not taking your eye off that. I just want to know, for interest's sake, of our mortality stats around COVID-19. When we see it in the media, it doesn't really tell us, what comorbidity or what underlying health conditions the individuals did have when it was stated as such. But how many of our death toll cases were HIV related?
That is something the ministry tracks. I have access to those data points, but it's really something that would be appropriate, I think, for the ministry to talk about. It's not a huge number. I'll say that. I don't want us to think that, well, yes, there are, what is it now? I think 628 Namibians who are reported to have died of COVID. It's a very widespread group, I'll say. It involves elderly people, middle-aged people, young people, children, although it is more shifted toward the older adults, as we would expect. It involves people with no other conditions, people who were completely healthy before COVID. It involves people who had either HIV or high blood pressure or diabetes or obesity or tuberculosis or cancer or some combination of those things. An important point, though, and you've probably heard me say this before because it gets mixed up a lot out there, is that these are not people who were going to die anyway of something else, and they just happened to have COVID. The COVID is not just a little footnote on their death. These are people in general who were surviving. They were survivors. They were thriving. Yes, maybe they had diabetes, but their diabetes was under control with medication. They were watching their blood sugar. Sometimes their blood sugar was a little too high. I'm just giving one hypothetical example. I'm living with diabetes. Some days my sugar is too high. I try to keep it under control, but I'm certainly not about to die from my diabetes. I'm dealing with a medical issue, a long-term medical issue. Then suddenly I get COVID and I get very sick and I end up in the hospital and I die. So should we say, well, that person died of diabetes, not COVID? Of course not. That would be very inaccurate. The COVID came in and led to that person's death. Did the diabetes contribute? Sure, very likely it did. And we can mostly see that by looking at a population level. If you see that people with diabetes are 3 times more likely, let's say, to die than people like them who didn't have diabetes, then we can definitely say that the diabetes contributed. But that doesn't mean that the COVID isn't what killed them. So the reason I think that's so important to get right is because the opposite argument, to say, no, they happen to have COVID, but it's these other things killing them, it's a way for people to really diminish the importance of COVID to say it doesn't matter, and ultimately to say we don't need to be spending our time or our energy or our resources fighting COVID because it's not that big a deal. And it's just not true. I mean, I wish it was. Honestly, I wish COVID wasn't killing people, of course. But when you see the excess deaths, the amount of deaths you would have had any other year, and then the deaths we had in 2020 and now in 2021 with COVID, and when you see millions of excess deaths around the world, no honest person can sit and say, well, those people were going to die anyway, just because they happen to have diabetes or they happen to be on a pill for their blood pressure. That's just not being honest with ourselves. We have to acknowledge that COVID is killing people. Oftentimes it's people who have other conditions, but that is not a reason to somehow ignore COVID. So people with HIV, yes. People with diabetes, high blood pressure, yes. But everyone's at risk, some at more risk than others. And the important thing is to get people the protection they need. And in those cases where they have some other condition that could be controlled, let's really make sure that that is controlled. It's more important now than ever to have your asthma under control, to have your diabetes under control. If you have the opportunity to lose weight, if you're overweight or obese, this would be a very good time to do that for your own health, because we know that being overweight is definitely a risk factor for COVID as well. So we can work on all these things.
Now, Doctor, there's also a lot of preliminary science linking COVID-19 vaccine to HIV treatment and vice versa. Do you mind telling us what the facts are in this regard?
I mean, right now, from what we know, people living with HIV should absolutely be out there getting these COVID vaccines just like everyone else. And the good thing is when you're on HIV treatment, your immune system rebounds. And the large majority of people in Namibia who have HIV are on treatment, their virus is suppressed, and their immune system is able to do a couple of things really well again. Number one, fight off all those bugs, all those germs that I talked about before, that if you don't have HIV, you don't get sick from them. If you have HIV and your virus is suppressed, you also don't get sick from those other germs. So that's obviously a very important part of HIV treatment. But another thing it allows is for vaccines to work the way they should. So when you're taking your HIV medicine, it's working properly, the virus is suppressed, you take a vaccine, your immune system knows how to respond to it, and you build up the immunity that you need. For people without controlled HIV, most types of vaccines, the vaccine doesn't hurt you, it's just, it won't work very well. You won't get the immune response we want you to have, so you have lasting immunity. But in the case of controlled HIV, the outcomes are going to be a lot better.
A lot of African countries, lashed out at the COVID, price for COVID-19, their slowness, and also, their sidelining of African countries. And the same cry was echoed in the late 90s and early 2000s, when the HIV, PMTCP, and ARVs were introduced. Why is this divide so loud, Doctor?
I mean, I think it's really complex, right? And you have a resource right now that is in extreme demand in every part of the world. When they started developing an Ebola vaccine just in the last few years, that Ebola vaccine, even though it was being developed in Western nations, it all immediately went to African countries because that's where the risk was. We didn't need an Ebola vaccine in the United States or Europe or Japan or Australia. It was needed in certain African countries where there was risk of new outbreaks. When new outbreaks did occur in the last year of Ebola, that vaccine was able to be pushed specifically to those communities that were then at immediate risk of getting Ebola. So it worked out very well. But right now we have a virus that's spreading in every country on Earth. So when a new vaccine comes out, it is very hard to get it everywhere because everybody wants it. What I can say though is that we've been here since the beginning. You've certainly been seeing my face a lot, but it's not just me, it's a large team of people. So speaking for my country, for the United States, we've had a team of dozens of people who have been on the ground working with Namibia on their COVID response, on protecting the HIV response during COVID since the beginning. And we didn't go anywhere. We stayed here. My country didn't ask me to come back and help with the outbreak in our communities. You know, my hometown, where I'm from in Michigan, is currently having one of the worst outbreak in America at this time. You know, and there's that part of your brain that says, maybe I should be helping there. But this is where I've been. This is where I've stayed the whole time, focusing on helping Namibia. And a very dedicated team has been doing the same and bringing in a lot of resources. As has been previously announced, the US government has given over 100 million Namibian dollars, and that number keeps growing, for the COVID response in Namibia. And that's not including the HIV money that has been continuing to come in, which in some cases has been modified how it's being used to do those things I talked about, protecting the HIV program and the people it's serving during COVID. So a lot of money, a lot of physical resources, a lot of people's time and efforts still coming into Namibia. And we see that story in other countries as well. So I don't think what we want to say is that Namibia has been left behind by any stretch. I think getting vaccine doses in country is challenging in this moment when the supply and demand is set up in a way that it's a real struggle for it to get spread out to every country in the world. But Namibia is not alone. And what we're seeing right now is a successful rollout of the vaccines that have been able to come in. And hopefully people out there who have access to it are getting it. I was just having a conversation literally in the last hour with somebody asking me my recommendations about what their family members should do in terms of getting the vaccine now or not. And I was encouraging it. I said, go out there and get those vaccines. Namibia now has WHO approved vaccines available in, I think, all of the regions at this point. I know the ministry has been putting out updated list of the different clinics where those can be made available. And we support that. We absolutely want as many Namibians to get that as soon as you can. Because what we're seeing in places like India right now, with this enormous new wave of cases that's worse than anything they've had so far in this pandemic, that could happen here as well. Namibia could be the next India, and we don't want to see that happen. I'm not saying it's likely. I'm not saying we have some reason to think Namibia will be the next India, but we're not safe from it yet. It could happen here. It's a warning for us to be prepared. And let's use that warning, just like we didn't have our first case last year until March. So we had 2 months to prepare ourselves before that first case arrived. We now have time to prepare ourselves before another wave, so we can be in a position that we don't have to be seeing those very terrible scenes like we're seeing out of India right now.
And just on the topic of India vaccinations, we have a question from a Facebook viewer who asked, will COVID ever have a cure vaccination? No, now that we know that the variants keeps on changing. For example, India is, one of the biggest producers of vaccinations, but currently has the highest and biggest daily numbers. Why vaccinate if the variant keeps on changing?
So there's a lot in that question. It is still very important to vaccinate, actually. The more that the virus is spreading, the more variants they can be. And I've explained this before as saying every person living with COVID is sort of like a big laboratory for the virus. The virus is making billions of copies inside your body every day when you have COVID. Tiny, we can't see them, these virus particles, extremely, extremely small, but the virus is using your cells to create billions of these things and churn them out, and then you're blasting them out of your breath when you cough, when you talk, when you sing, when you breathe, in hopes, from the virus's perspective, in hopes of finding another person to infect, to become another laboratory to churn out much, much more virus. So the more people are infected, the more virus that's being created. It's not trying to mutate, right? The virus is not thinking. It doesn't have a plan per se. But every time it makes a new virus copy, there's some chance that it'll mutate just a little bit. And most of those mutations won't help the virus. Most of them could actually hurt the virus. It could make it less likely to be able to reproduce well. But if you give it enough chances, billions and billions of chances across the world, sometimes the right mutation will happen that actually makes that virus stronger. And then that's the one that's going to spread better than the other ones. So you're going to see more of it and more of it and more of it. So we need to get less people on Earth infected with this virus, so less mutations are likely to show up. The more cases we see every day, the more likely that a mutation will come around. The mutations are not making the vaccine irrelevant, though. The vaccines are still working, some of them better than others, and it depends on the variant. Some vaccines work very well against some variants, sometimes not as well, but we're still talking about some level of protection. And if we get as much of the community as possible with as much protection as possible, the virus will eventually stop circulating. So I actually would flip the question around and say, because of the variants, we can't afford to stop vaccinating, because the virus will only keep getting stronger and stronger and stronger if we give it an unlimited number of laboratories to eventually come up with a way to be even more dangerous to us.
All right. Well, I hope that answers our viewers' question. Also, David Bishop, who's joining us here via Zoom, has a question. David is saying, we're blaming vaccine nationalism for the delay in receiving vaccines, but in more than one African country, vaccines have had to be destroyed because of vaccine hesitancy, and even here our numbers are low. How do we best tackle this problem?
Yeah, it's heartbreaking to hear stories like that when a country has to destroy their vaccine supplies because it came in and they weren't ready to actually get it out to people. And by the time they were, it was expired, not appropriate to use it anymore. And then it was completely wasted. That is a tragedy. We are not in that situation in Namibia, and I feel really good about that. Again, I can attribute this to planning that took place. So we may have only gotten our first doses of vaccine in the last several weeks, but there has been vaccine planning here for months. I know that because CDC has been closely involved with it. It's been led by the Ministry of Health. It's been multi-sectoral. It's pulled in people from all sorts of different areas because, you know, you need a lot more than a doctor to give a vaccine. It's about supply chains. It's about storage capacity. It's about trainings. It's about a lot of things that will make that system work. So that was all happening for months and months till the first doses showed up. And I think there were probably some people that at the time thought, well, that's kind of a waste. Why are we spending money for a vaccine program that currently has 0 vaccines? But it means that when the vaccine showed up this year, Namibia was not one of those countries that sat on it and let it expire and threw it away. Namibia was a country that immediately started getting it out. And what you saw in Namibia was that it got the access to the vaccine spread really quickly. You probably noticed at first it was only for very high-risk people, but then very quickly it became additional groups were eligible, and then more and more. And now anybody can go and get a vaccine. And that's because they absolutely, they meaning the Ministry of Health leading it, but all of us involved, we don't want to see a single dose thrown away. So a lot of effort is going into making sure that they all get used before they expire. And that's why you see this strong push to get it out quickly. So I would say it's something that I'm really proud of, that we all work together to have a system in place. So when the vaccine first showed up, we were ready to push it out immediately. There are a lot of countries out there that can't say the same thing.
Yeah. Another one of our Zoom participants, Malti Mertens Shikongo, asks, as a country, how do we prepare or avoid the second wave, knowing that not everyone is adhering to regulations?
Yeah, and I see that earlier question from that same person about, you know, what the vaccine is for. So let me say this, you know, the vaccine doesn't kill the virus. It's not a cure. The vaccine gives your body immunity to the virus before you get it, so that you're able to fight the virus away and not get sick from it, not get actually infected from it when you're exposed, because you get to cheat. You get to have the protection from the virus before you even get the virus exposing your body. So one of the ways that we can avoid the second wave is by getting as many people vaccinated as possible. Actually, I should say we've had what I would call 2 waves. We had a wave already that really was peaking in July and August. That one was mostly seen at the coast and then in Windhoek. And then we had a worse second wave that really was peaking in December, and then still had a lot of cases in January. And that one was the more widespread wave that was hitting all the parts of the country. So it's a third wave that I would be concerned about. But you're right, not everyone is adhering to regulations. And they never will. We'll never have a point where we say everybody adheres to regulations. There will always be people resisting it. Honestly, I don't understand it sometimes. I see people walking around with their mask on their chins, and I don't understand after over a year of this, why people would think that's a good idea when you're in the shops, when you're in a public place indoors, to have your mask down like that. It's just, we don't pull our pants down in public. Why are we pulling our mask down in public? It's not a personal liberties issue. It's just common decency to the people around you. So this is something where we can't wait for 100% of the population to be on board. We need to all be doing our part. Some of that is public policy, and we still see policies in place in Namibia to make sure that we don't invite that third wave. So we still have restrictions on gathering size. We still have curfew. I don't think these things are meant to be overly burdensome. And within this context, a lot of business is able to still thrive, right? This is not a shutdown. We're not in lockdown. We're not in a shutdown. This is not about crushing the economy. This is about some common sense measures so we don't just jump backwards and go into a much worse wave, and potentially worse than the ones we've had before because of the variants or other reasons. We don't want to be in that situation in Namibia. That won't help our economy, and it certainly won't help people's health. It's not going to stimulate any additional confidence in Namibia or ability to progress in schooling our children and keeping our businesses open if the hospitals are becoming overwhelmed like they are in some other parts of the world. So yeah, I wish everyone was adhering. I wish that we were all in the same boat, but that's not the case in America. That's not the case in South Africa. It's not the case in Namibia. It's not the case anywhere. We need everyone to do their best. And if you see other people not adhering, you just maybe have some thoughts about them in your head. I certainly do, but you move on. You keep doing what is possible.
Yeah, no, I actually call them out in public. I ask, why are you not wearing a mask? And can you please cover your nose and your mouth? And I think as much as I do my part in wearing my mask properly, I also would like to ensure that my fellow Namibian does that. But nonetheless, Dr. Dziuban, before I continue on to our next question for you, I just want to invite all our Facebook participants that are watching, please, if you have a question, to put it through on our comment section on Facebook, and also to our participants that's joined us on Zoom this morning. Please do filter through your questions for Dr. Dziuban in the chat box. Now, Doctor, the CDC believes, in real-time science, and you advise host governments in shaping the responses. What is the advice that you gave the host government that you felt was not heeded, and perhaps also tell us how different you think things would be if the host government did take up this advice?
I mean, we've been involved in these conversations since January of last year. It's an ongoing thing. It wasn't just one chunk of advice or a monthly envelope. Here's our advice for the month. It is a constant dialogue. There are times that it involves some disagreements, and I would say not disagreements between CDC and Namibia. We were one team working together. And so you would have health workers from within CDC, within the Ministry of Health, all across the response, WHO, and then there might be disagreement between experts or advice moving up to country leadership, and then they have the decision whether to take the health advice or not. Let me first focus on what I think really impressed me the most was that there was an openness to that advice and a willingness to have us engaged and having the data available to us. That's not a given. It's not always the case that a country like Namibia or any other country would have people like me, a foreigner, somebody who's here from another government, and allowing me to see the data. But here in Namibia, that happened, and it's happened all the way through. Myself and my team, we've been invited to the table to see all the data about all the cases throughout this entire outbreak. And that makes a big difference, because I would argue that I was able to offer much better advice because I knew what was actually happening. It would be very easy for a country to become very protective and to start hiding their data and to say, you can't look at these. We will look at these case reports. We will decide what can be made public, and you can see that. Well, how good could my advice really be, or my team's advice really be, if all they were seeing was the filtered reports of what was happening in Namibia? That's not what happened here. We truly, I honestly say this, we have been allowed at the table throughout this pandemic to see the data in its original form. And because of that, I think we've been able to offer the best possible advice. And usually that advice aligned with what the health experts in Namibia wanted, and it was able to be presented, and it was able to be enacted. And that's a really good thing. Let me also say that never once, I'm saying this genuinely, never once since the beginning of this was I ever asked by my government or by the Namibian government to say something disingenuous. I've been able to be honest the whole time. I was never told, censor that, you're not allowed to talk about, you need to talk about it in this way, pretend this or that. Now that doesn't mean that, of course, you know, I was always like handing the media people's personal information. Of course not. It doesn't mean every detail of every conversation was divulged, right? I'm still ultimately in a space I would call health diplomacy. And part of health diplomacy is, of course, not just speaking ill of everybody that you're working with. So not in any way am I saying that all the things we talked about were aired, but I never had to be dishonest. Whether I was, you know, I'm looking at the names of some of the journalists that are here, and I spoke to you throughout the last year. And when you asked me questions, I was able to answer them honestly. I was not told to hide the truth. And I hope that was useful, because I wanted to be a voice of honesty and presenting the science, being factual in a way that the Namibian public could trust. Other people were being honest. I'm not saying I'm the only person that was being honest out there. And I saw a lot of trusted advisors coming from other sectors, from government, from WHO, also being honest. But I appreciated not being censored. And I think it's something that hopefully the media can appreciate as well, that spokespersons were being put forward, that you were allowed to ask questions of, and that you were getting things straight, that you were getting honesty from me and others. So to me, that speaks of a very healthy relationship between Namibia and the partners that have been here supporting their work, the work of the government here since the beginning. When we see the regulations are continuing, we know that that's a decision that's being made by the highest levels of government. And so the process is that we give our best advice in these technical areas. It goes to the leadership of the Ministry of Health. And then ultimately it's the president and it's the cabinet that's making these decisions for the best of Namibia. And we know that that's their right to do. Namibia is a sovereign nation, and they're going to choose to handle this pandemic the way they want to, just like every other country does. That's their right. But I do appreciate that we had a seat at the table. Our advice was never censored. The data that we saw was never censored. And I think at the end, that was a win for everybody. Namibia wins because you had more people collaborating on this response.
Yeah. Well, Doctor, I don't know if there is, but you know, what is the most obvious singular solution that we have been missing, if we've been missing anything? And is it too late to pursue that where COVID-19 is concerned?
I think the answers are the ones that are in front of us. There's nothing flashy or new to present today. It's the things that I think we all have seen have stood the test of time. Wearing the mask, distancing ourselves, avoiding gatherings when we can, staying home when you're sick. That's a big one. I think that's gotten easier. Somehow at the beginning of this, if you were feeling sick, you just felt like, but I still need to somehow push my way into work. And over this year, I think we've shifted as a culture in recognizing, no, it's not helping anybody if I'm sick and I go into work. It's absolutely the wrong thing to do. So we knew that these things were going to make a difference pretty early on. I will say the mask, that was something that we didn't start saying right away. We didn't have the evidence for that right away. So when I was talking to you back in January or February of March of last year, I wasn't saying everybody should be wearing a mask whenever you're in public. And that's not because we were lying or hiding anything or getting it wrong. That was just the evidence we had at that time. We knew that healthcare workers needed those masks. We knew back then that there was a limited supply of them. But as time went on and the virus spread more widely, the masks became more available, the evidence became clear that was the right thing to do, was for everyone to be wearing the mask in those settings where the virus could be spreading. And it's still true. It's still true. So that's all held up. Now, of course, we also have the vaccines. So that is going to be a part of the solution as well. But we can't rely completely on the vaccines. And just because you have 1% or 5% or 10% or even 40 or 50% of your population vaccinated, that's not going to be the only solution. You can still have outbreaks. You can still have deadly waves, even with millions and millions of people vaccinated. Look at India. Many millions of people vaccinated, but many more people than that still unvaccinated. And now, unfortunately, that wave hit them at a time that they're not protected yet, and it's having devastating results. So we don't want that to happen here next, but we were already figuring out how to protect ourselves before a vaccine was available. So as this vaccine rollout goes on, hopefully more and more and more people do get vaccinated. We still have that opportunity to do the things that were working in 2020, continue doing them in 2021. The worst thing we could do right now is just say, it's time to let go of those old measures, because that's what got us out of the mess in the first place. We need to stick with what works.
Doctor, I see that we have 11 participants now. I just want to tell our participants via Zoom, please, if you'd like to a question through to Dr. Dziuban, just raise your hand. You can ask him directly. You don't necessarily have to use the chat box. But there is a question from David Bishop. David, I'd like to give you the floor, actually, and you can ask Dr. Dziuban your question directly.
I will do. Hi, Dr. Dziuban. Just like I said in the question, I know the conversation's taken a different direction a bit, but on the theme of COVID and HIV, what's your opinion, or let's say possibly your hope for the future of the mRNA technology that was developed for COVID vaccines, then being successfully deployed to create a vaccine/cure for HIV/AIDS?
Yeah, great question. Let me just say that in terms of the theme, I feel like I feel comfortable letting it go, wherever all of you would find it more useful. For me, a lot of this is a last chance to speak to the media. I move on Monday. I'm leaving Namibia, and so it's been great. One good thing out of a really tough year for everyone with COVID, one good thing was just getting to have more media engagement, get to know a lot of you, and the messages you were getting out to the public. So I just feel privileged to be able to have one last chance to talk to the media. So I'm happy to go broad. And the theme of COVID and HIV, it's not just how those two viruses interact, but also the idea that the solution for both is the same. And ultimately, it's to follow the data. It's to use the data and understand it so that science is driving the response. And in so many ways, even though HIV and COVID spread in very different ways, they operate very differently in our bodies. Ultimately, it's that same approach of identifying where are the cases happening so that we can do prevention efforts to stop transmission, and then identify when people are infected, getting them the treatment they need and helping them prevent spread to more people. In a lot of ways, it does work in a similar fashion. And so that is something Namibia and other countries can learn from to not just strengthen their HIV response, but be ready for the next pandemic after COVID. But to your specific question, the mRNA vaccines, that's also a bright spot of the last year, was how successful they've been so far. There are two of them, the Pfizer and the Moderna. They were two of the very first to be developed. And that is because of this mRNA technology that was already in the works. So before we even knew about this particular coronavirus, they were developing this platform, a brand new platform for how to develop vaccines, so that this virus could then be brought in once we have the genetic structure of this virus, and by using this platform, get to a vaccine faster than we ever had before. And we know that happened. It was very fast, but we didn't know if it would work or not. And as it turns out, they've worked very well. They've been some of the strongest performers in terms of coverage, and even their effectiveness against variants and such. So we're still learning, of course, about the long-term efficacy of them. Will we need boosters in the future? Will we need updated versions of these based on the variants? But it is exciting. And yeah, I want to see it work for a whole lot of other diseases. HIV is so tricky because it's a retrovirus. And without going into too much deep science, the way that that particular type of virus works, it's just constantly reinventing itself. And so getting a vaccine for HIV has been so tricky in that way. And people have been working on it for decades, and it's eluded us. Could mRNA vaccine technology be the key to finally unlocking AIDS vaccine? I would love to see that. I really would. My guess would be, if I had to guess, that maybe certain other viruses will see success with mRNA vaccines before HIV. Again, just because of that real trickiness of retroviruses in particular. That's why there's not just one HIV medication you take. Even people who are on one pill once per day, which most people in Namibia are, they're taking very good HIV medicines, some of the best we have in the world. They just take one pill once a day. But that one pill actually has 3 specific different medications in it, because you have to attack HIV from multiple places all at once. Because if you just attack it in one way, it can very quickly mutate away from that drug and become protected or immune to the drug much faster than COVID does. So this is just the nature of HIV and why it's been such a challenge for the whole world for over 30, going on 40 years now. But yeah, I'm hopeful. And this, again, it'll be probably one of the best things that came out of 2020 was for mRNA vaccines to come onto the scene and give us a new weapon against not just the coronavirus, but a lot of viruses.
David, I hope that answers your question. Anybody else with a question, please do raise your hand and you can just filter it through directly to Dr. Dziuban. But while we're waiting for a question from one of our Zoom participants, Doctor, we know that obviously, or we don't know rather, how long this pandemic is going to be a reality for us and how long it's going to be around. And in terms of, interventions, you mentioned around HIV and COVID-19, you said just follow the data. But, I just want to know if you can mention just a few successful HIV interventions that we could employ to navigate, the murky waters brought about by COVID-19. In layman's terms, what does follow the data mean?
Yeah, it can be tricky. So let me give an HIV example. We've been talking for a long time about something called 90-90-90. And those were UN AIDS goals. The United Nations set these goals for by the year 2020, that 90% of people living with HIV would know their status, 90% of them would be on treatment, and 90% of those people on treatment would be virally suppressed. The treatment was working, the virus levels are so low in your body that it's not actively harming you. 90-90-90. You can't get there without data, right? You don't know if you're there without going out there and doing surveillance and knowing how many people are living with HIV in this country. How many tests are we doing every year? Of those people tested, are they getting linked to treatment? How many people are on treatment? Are the people who were on treatment last year still on treatment this year? Are we checking their viral load? What are our laboratory results for viral load? How many of those people on treatment are coming back with lab results that show the virus is suppressed versus not? And not just doing that for the country, but breaking that down district by district by district, men versus women, age categories, looking at 20 to 25-year-olds versus 25 to 30-year-olds versus 30 to 35-year-olds, every different age category, looking at people with particular risk factors. It goes on and on, lots and lots of data. Because Namibia was following those data closely, it knew where the gaps were. So instead of just saying, well, I think we need to do more work on getting people on treatment widely, we were able to say things years ago, like, we know that Zambezi is an area that has particularly a low viral suppression. So let's focus on viral suppression there. But we know that Omaheke is a place that's particularly low treatment coverage, just even finding the people and diagnosing them. So let's take those resources and send more to Omaheke. And we know that ultimately, and this is true right now, most of the people living with HIV that still haven't been diagnosed are here in Windhoek, because that's the main population center. So if we're looking at the absolute numbers, even though the percentages in Windhoek are good, that's still where the bulk of the people that we need to find and support to get on treatment are living. So the data lets us take the resources and push it where it's most needed. And that would apply for COVID as well. Because Namibia was doing that, we hit those 90, 90, 90 goals 2 years early. And that was incredible. That was a real accomplishment. Now we're talking about 95, 95, 95. And UNAIDS wants every country to get there by the year 2030. And I'm confident that Namibia is going to beat that target as well. So that's an example, I think, of the way that we would use data. There's something new that Namibia is using called recency testing. When someone is found to be living with HIV, when we test and they're positive, there's an extra test that could be done that can actually tell us whether that HIV infection is from the last year or whether it's an older infection as well. Is that going to change the treatment that person starts? No. The person's medical care will be exactly the same, whether they just got infected with HIV in the last year or whether they've had that HIV for many years in their body. So you might say, why bother doing that extra little test to tell whether the infection was recent or not? But that's the public health approach I'm talking about. It's not just about what does this individual need, but how do we help the whole public? And we can help Namibian more if we know which populations, which communities, which geography is seeing more recent infections, because of course that's where we want to go with our prevention interventions. That's where we need to go. Stopping new infections is where they're happening right now, because ultimately we can't do anything about people who got infected 10 years ago in the sense that, you know, stopping transmission. It happened 10 years ago. We can get those people on life-saving treatment. But if we want to talk about stopping transmission, preventing new infections, we need to know where it's happening today, not 10 years ago. So this is a new laboratory test that can help us do that. And again, it's a way that following the data is going to get a better response. And it's not just happening in fancy corners of the world that have very expensive, very high-tech health systems. It's happening right now in Namibia. And so let's use that same approach, that same way of thinking for COVID and the next pandemic as well.
Thank you, Doctor. Malti Mertens has put through a question in the chat box and says that they prefer not to talk, so I'll read it for you. It says, for COVID-19, we have a variety of options on how to prevent ourselves from it. For HIV and AIDS, from my experience, we only have condoms. Is there any other ways to prevent AIDS? Just asking. That's the question from Malti Mertens.
Yeah, there are. So there is a lot we can do right now to prevent AIDS. Condoms are a part of that. We don't turn your back on your old trusted tools when they still work. Hammers have been around for, I don't know how many hundreds of years. If I'm putting a nail in my wall, I still grab a hammer. It works. I don't need to throw it away because it's old technology. The masks work. They worked back during the Spanish flu 103 years ago. They work today. For HIV, condoms still work. So we don't need to throw those away. But it's not our only tool. And there is something called PrEP that maybe some people have heard about. PrEP stands for pre-exposure prophylaxis. That's a mouthful. But what that means is you're taking a medicine before you're exposed to HIV so that when you do get exposed, you will not get infected. The HIV can't take hold in your body. You would basically just flush it out because you already have the medicine in your blood, so that HIV doesn't have a chance to lock in and get trapped in a lifelong infection. So it's called PrEP. And it's something that absolutely people can go to their clinics and talk about. It's being rolled out in Namibia. We're really focusing on people that were the most concerned that they might get HIV in the near future. So this is not for people who are HIV positive. We have medicine for people who are HIV positive. We call it ART. That's the treatment if you have HIV. These are very similar medications, but we use it in a different way, and we call it PrEP. And it's for people who do not have HIV, but they could get it in the near future. They take PrEP to prevent it. And so particularly people that we know are at high risk, that are engaged in activities where it's more likely they could get HIV soon. One area of focus that we're going to have in the coming year, and I'm talking about the Ministry of Health supported by us at CDC and USAID, is getting more PrEP specifically to pregnant women. Because something, again, following data, watching the numbers carefully, we've seen something concerning, which is women who get pregnant, they get tested for HIV when they go to the clinic. Namibia does a very good job of testing women as soon as they find out they're pregnant, see if they have HIV. If they do, they get on treatment. But if they don't have HIV, we're finding that unfortunately, way too many of those women get HIV. They get infected during the pregnancy. Being pregnant seems to be a time of a special risk for a woman to get infected with HIV. And then having a new HIV infection in her body that she doesn't know about yet, she is then at high risk of giving it to the baby as well. So making PrEP available for pregnant women so that during that particularly vulnerable time of pregnancy, they are not going to get HIV that they will be trapped with their whole life, and then possibly give it to their baby to have that child's whole life as well. That's just a key place where we can intervene. And it was because we were watching the data closely that we could see that this was an area of need and then push resources toward it. So any of you or anyone you know that's getting pregnant in the next year or is pregnant right now, this is something you might hear talked about in your clinic visits, is getting on PrEP so that you won't end up, unfortunately, getting HIV during that time in your life.
Thank you, Doctor. Another question from Ricardo Hoxlip. He says, with COVID dominating the news cycles locally and internationally, how can we make sure that HIV and other health issues do not completely disappear from the mainstream national discourse?
Well, I think this session is a great example of how that works. And we're tying the two together, and it's not just to bring attention back to HIV. You know, that's a very common strategy, right? In any kind of public advertising or journalism, where you take something that everyone's talking about and you try to tie it into this other thing that you want them to pay attention to as well. It's not that. It's actually that there are relations between the two. The viruses relating to each other, as we talked about early in the session, but also the approach being similar. We don't have to reinvent what a public health structure looks like, what a public health response looks like. Every time a new virus comes around, we have these tools, we have these processes, we know they work, and we can adapt them for every time we see a new threat coming, and we'll all benefit from that. So I think talking about it in these ways helps. We've obviously still tried to get the messages out about HIV. Some of those are in the widespread media. You know, I know just in the last week, there have been news stories because the executive director Ngombe was talking about the numbers of HIV cases and deaths that are occurring. Again, with all the data collecting we do, we being that whole team of people working on HIV in Namibia, there are those opportunities to have stories coming out to really talk about which populations are most at risk, or which parts of Namibia have been seeing the best results or have the farthest still to go in terms of treatment coverage, things like that. So we do find ways to get it out to the public. Sometimes it's more about targeting the message, right? So when I talk about pregnant women having this new option to make sure they don't get HIV during the pregnancy, you can spread that to the public widely, and that's what I just did today, but you can also make sure that that's being talked about in the clinics, in the antenatal clinics where those women are going to seek medical care. That's a very targeted way of messaging about that issue to get to the exact people that need to hear it. So a lot of that is happening as well. And if you're just a member of the public and you're not in one of those groups that's being a focus for that messaging, you might not know it's happening, but it is.
Well, Doctor, we're coming to the end of our session, but just reflecting on your tenure here in Namibia, what is one key attribute, that we need to continue capacitating on, not only to deal with these pandemics, but, that will serve us well for future public health crises?
Well, I've been here 3 years. It's been a remarkable time in my life. I'll never forget Namibia. It's a truly incredible place. It's a beautiful land. The people have this strong connection to the land here. The land is harsh in a very beautiful way. It's a harsh physical environment, but the people are not harsh. The people are warm, they're friendly, they're inviting. I've been treated so well. My family has been treated so well, which is so important, right? I couldn't have been happy here if my family wasn't being treated well, but they were. And it's been an honor to serve here. I will take a lot of lessons away. I was telling some of my closest colleagues at the end of last week in saying goodbye, I'm relatively young, and I grew up in an age where AIDS and HIV was already there. People that are 10, 20 years older than me, they remember when there was no HIV, at least that we knew about, and then they watched it show up into this landscape. They watched it get discovered and become something new. For me growing up, it was already there. And it just seemed like an impossible problem to solve, right? It was the big problem in the world, AIDS. It just felt like this thing that we would never be able to fix. There was no treatment, there was no vaccine, there was no hope. That's what it felt like. And it's slowly over time, some countries started getting medicine, they were able to start getting under control. But still, what about Africa? Africa has more cases than anyone, and they don't have those medicines yet. So how are we going to control it? Well, over time, those medicines came to Africa as well, and PEPFAR was a huge part of that. But I was working in a different country in this region 11, 10 years ago, and even at that point, it seemed like an impossible problem to solve because so many people still were getting infected every day. I was literally watching people die of AIDS all the time, going to funerals, doing things that I just don't want to be a part of my life, watching children die frequently of a treatable disease, but it was still happening so much. And now in these 3 years in Namibia, I'm not saying the problem is completely done yet. There's still ways to go. People are still suffering here from HIV, but the numbers are really good. And you have taken an unsolvable problem like AIDS, and you've figured out how to solve it. You've gotten HIV epidemic control within reach so that the large majority of people living with HIV have bright futures ahead of them. They don't have to fear an early death. They can get a simple 1 pill once a day treatment that can give them their futures back. That means a long life of doing whatever you plan to do before, graduating school, getting married, having children without HIV, having a career. All those things are possible again. So that's the biggest lesson for me that I learned from Namibia. You took an impossible problem and you solved it. You made it possible, and that was incredible. There's a lot of details into how that happened. It wasn't just a quick wave of a wand. It was a lot of hard work from a lot of people for many, many years. So I'm going to learn from that, and I'm going to bring those lessons to the next place I go. I will learn things there as well. I'm moving to Vietnam, another country with an HIV problem, a similar number of people living with HIV, but in a different population. It's a more focused population because those 200,000 people with HIV are concentrated in a country of about 98 million people. So different tools being used, but I'm sure I'll learn things there as well. I hope to bring some of the lessons of Namibia to that job. Maybe I'll even learn lessons there that I can share with colleagues that are remaining here in Namibia. But the work continues, and Namibia, I think, really showed how a partnership like we had, CDC, the Ministry of Health, those partnerships are not always strong in every country in the world, but in here it really was. And a lot of good came out of that, and I'm excited about it. David, you had your hand up. Did you did you want to ask something else?
No, Dr. Dziuban, I just wanted to actually hijack the end of the session just to personally thank you on behalf of Future Media for everything you've done, for always being approachable, always being willing to talk to us. And maybe you can just leave a note for whomever takes over from you that they carry on where you've left off for us. It's been amazing having you as someone that we can get hold of. Thank you.
Thank you for saying that. It's been a pleasure.
I don't know if anybody else has a question. Unfortunately, I missed your response to mine, Dr. Dziuban. But just as closing remarks, anything that you would like to leave us with this morning?
I would leave you with just saying, again, thank you. Thank you to Namibia for treating me and my family so well. Thank you to the media for taking this pandemic very seriously and your role in it very seriously. I'm being genuine here. I've really been impressed. I feel like by and large, the Namibian media truly been responsible during this pandemic, not falling into the one extreme of sensationalism and just drumming up fear and panic, but also not going to the other extreme of being dismissive or perpetuating these myths about, that would diminish the virus and the seriousness of it. I felt like the media really tried to find truth, tried to seek out answers, legitimate, scientific, factual answers, and present those to the Namibian people. And so they owe you a debt of gratitude as well. You are essential workers, and you did your jobs well in this last year, more than a year, fighting this pandemic. I know you'll continue that. Thank you for doing so. CDC will remain a partner in that. You can still reach out to our agency. I won't be here, but a lot of incredibly smart people remain in my office. They're very good at their jobs, and I know they'll be happy to continue engaging in ways that can be helpful to the country. So it's not over yet. Please continue to fight this fight, and just, thank you for giving me a chance to share my voice with Namibia and do my part this year as well.
Well, Dr. Dziuban, thank you for taking the time out to speak to us this morning. I know you mentioned earlier that you leave on Monday. We wish you and your family all the best, and all the best for your future endeavors. And like David did say, we hope that whoever will be replacing you will be just a joy to be able to work with, as part of the media fraternity. So thank you for your time. Thank you to all our participants this morning on Zoom and on Facebook. This recording will be available up on YouTube on the Namibia Media Trust page, hopefully by tomorrow, so you can catch the full discussion there as well. But thank you and goodbye to everybody.